The next presentation will be by Dr. Mitrousi, CMR in dilated cardiomyopathy.
Well, good morning to everyone, and I'd like to thank you and congratulate the organizing committee for this very nice educational course once again, and especially Professor Mavroheni. So my talk today is about cardiac MRI in dilated cardiomyopathy. Non-ischemic dilated cardiomyopathy is the presence of LV dilatation or biventricular dilatation and global or regional systolic dysfunction in the absence of abnormal loading conditions or very severe coronary artery disease. There is an estimated prevalence of the disease in about 2,500 individuals. It's a major cause of heart failure with reduced ejection fraction. It's the most frequent indication for heart transplantation, and unfortunately it's quite heterogeneous. So there are plenty of causes of dilated cardiomyopathy, with genetic ones to be 50% of the case. Infection, like post-myocarditis, but again, as previously said in the previous talk, there might be a genetic effect here as well. Autoimmune and autoinflammatory disease can lead to dilated cardiomyopathy. Toxins as alcohol, cocaine, amphetamines, iron overload, etc. Drugs that use in chemotherapy, immunotherapy, antipsychotic drugs, endocrine disorders, metabolic disturbances, and peripartum. We always need to keep in mind that there is a clinical spectrum of dilated cardiomyopathy with a preclinical or early phase and a clinical phase with hypokinetic non-dilated cardiomyopathy and dilated cardiomyopathy. There is a progressive expression of the phenotype in the patients. And speaking about hyperenhancement patterns, on the left-hand side, we see the ischemic pattern, which follows coronary distribution with subendocardial territories and transmural, and the non-ischemic hyperenhancement pattern, where it might be midwall fibrosis or epicardial fibrosis. The new 2023 ESC guidelines for the management of cardiomyopathies highlights the key role of cardiac MRI in ventricular myocardial scar assessment. And as you can see, the contrast-enhanced cardiac MRI is now recommended in patients with cardiomyopathy at initial evaluation. So here we can see some examples of cardiac MRI imaging tissue characterization features that should raise the suspicion of specific etiologies according to cardiomyopathy phenotype. So when we see increased short T2 star sequences, it leads us to diagnosis of hemochromatosis. Subepicardial late gadolinium enhancement leads us to think about post-myocarditis. Lateral wall epicardial late gadolinium enhancement leads us to think about dystrophinopathies. Subepicardial and midwall late gadolinium enhancement at the basal septum or with an extent to inferolateral wall and RV insertion points leads to think about sarcoidosis, and apical transmural late gadolinium enhancement is a common characteristic of Chagas disease. The 2021 ESC guidelines for the diagnosis and treatment of acute and chronic heart failure recommend cardiac MRI for the assessment of structure and function of the myocardium, especially in those with bad echo windows. CMR is recommended for the characterization of myocardial tissue in suspected infiltrative disease, Fabry disease, inflammatory disease, LV non-compaction, amyloid, sarcoidosis, and iron overload. CMR with late gadolinium enhancement should be considered in dilated cardiomyopathy to distinguish between ischemic and non-ischemic myocardial damage. And this is a two-way indication. But why do we use cardiac MRI here? Cardiac MRI is a non-invasive imaging technique. Independent of acoustic window, it can be used when patients have bad echo windows. It's the gold standard for LV and RV volumes and ejection fraction measurement. It can give us the tissue characterization, and it can help in diagnosis and prognosis of the disease. Serial follow-up cardiac MRI every 2 to 5 years is crucial for disease progression evaluation. Are there any limitations? Unfortunately, there are. Patients with irregular heart rhythm as atrial fibrillation or ectopics, patients unable to follow breathing instructions, patients claustrophobic, or patients with implanted devices are few of them. So there are quite a few studies regarding the role of late gadolinium enhancement and prognosis of non-ischemic dilated cardiomyopathy. And this one is from Gulati et al., which shows that both presence and extent of mid-wall replacement fibrosis are associated with increased likelihood of all-cause mortality in non-ischemic dilated cardiomyopathy. It also showed that the assessment of mid-wall fibrosis with cardiac MRI provides independent prognostic information in the disease. Late gadolinium enhancement itself improves risk stratification beyond ejection fraction measurement for all-cause mortality and sudden cardiac death. As we can see on the upper panels, we see on the left-hand side the image on a cardiac MRI of a patient with near circumferential pattern of mid-wall fibrosis. And on the mid and right panel, we see the extensive replacement fibrosis on microscopic examination. Which CMR protocol is used in suspected dilated cardiomyopathy? We always start with the basic CNA imaging sequences, followed by T2 weighted sequences, pre- and post-contrast T1 mapping, and of course late gadolinium enhancement sequences. As this is an educational course, I'd like to give you a few of our cases from our labs. So the first case is about a 61-year male patient who was referred to our lab because of new onset heart failure with reduced ejection fraction. There was no critical stenosis of coronary arteries in the angiogram, but echo showed dilated LV with local hypokinesia, an ejection fraction of 27%, and bilateral dilatation. There is a history of excess alcohol abuse, and our patient is a smoker. So as you can see from the CNA images, on the left-hand side, 4-chamber CNA, 2-chamber CNA in the middle, and the right chamber CNA images on the right-hand side, we have severe LV dilatation with RV systolic impairment, with an LV ejection fraction of 19% and LV end diastolic volume of 182. Native T1 measurements were within normal limits, as the extracellular volume, and of course RV is compromised. So you can see there's global hypokinesia. And this is the CNA stack images of the same patient. After providing gadolinium, as you can see, there is no evidence of myocardial fibrosis. And this is the late gadolinium enhancement stack. So the findings are in keeping with dilated cardiomyopathy without evidence of fibrosis, and the most likely etiology is alcohol abuse. The second case is about 58 years female patient who was referred to our lab because of new onset heart failure with reduced ejection fraction. Patient had a chest infection 3 months ago, and since then shortness of breath, gradually getting worse. She went into an angiogram where no critical stenosis of coronary arteries found, but her echocardiogram showed dilated LV with an ejection fraction of around 35% with diffuse hypokinesia. So the CNA images here shows an ejection fraction of 32% with a very high LV end diastolic volume of 163. And pathological native T1 values, mildly pathological, and T2 values within normal limits. And here is the scene stack where we can appreciate the global hypokinesia. After providing gadolinium, as you can see, there is a subtle mid-wall fibrosis of the basal septal wall, seen in the stack images as well. So the findings here are in keeping with non-ischemic dilated cardiomyopathy with subtle fibrosis at basal septal LV wall, and the etiology most probably post-myocarditis. The third case is about a 16-year male patient with shortness of breath, palpitations, chest pain, and episodes of loss of consciousness after suffering from chest infection 2 months ago. His echo was showed a mildly dilated LV, severely impaired LV ejection fraction of around 30%, and the patient has a history of learning difficulties in the spectrum of autism. So referred to us for a cardiac MRI. He could not keep his breath very well, and he had quite a lot of ventricular ectopics. Ejection fraction was calculated 17%, mildly dilated LV, and RV was compromised as well. And here the scene stack shows a circumferential pericardial effusion. After providing gadolinium, there is an extensive mid-wall and subepicardial fibrosis in almost all the LV walls. Circumferential large pericardial effusion, as we said before. So the findings here are in keeping with non-ischemic dilated cardiomyopathy with extensive fibrosis and large pericardial effusion. Most likely etiology is post-myocarditis. Our patient is referred for cardiac transplantation. And we're going into case 4, a 64-year male patient with new onset heart failure with reduced ejection fraction. An ECG shows atrial fibrillation. An echo shows mildly dilated LV with severely impaired systolic function with an ejection fraction of 28% and global hypokinesia. No critical coronary stenosis on the angiogram, and a history of Lyme disease post-journey to the United States. So our patient had his cardiac MRI, which showed an ejection fraction of 28%, mildly dilated LV, and compromised RV. Native T1 values are pathologically elevated, T2 within normal limits. And this is the scene stack of the same patient, real-time images as the patient was on atrial fibrillation. After providing gadolinium, one can appreciate mid-wall fibrosis at the basal septum. And here is the stack of the late gadolinium enhancement image. So here the findings are in keeping with non-ischemic dilated cardiomyopathy, and the most likely etiology is undiagnosed Lyme carditis. And our last case is about a 14-year male patient presented with palpitations, and his physician referred him to us for further investigation. He has a history of Duchenne muscular dystrophy. And here is his scene images with mildly reduced ejection fraction of 51%, normal end diastolic volume of his left ventricle, elevated native T1 values and extracellular volume of 39%, and normal T2 values. As you can see, his scene stack as well. After providing gadolinium, we can see subepicardial fibrosis at basal mid lateral wall, basal mid anteroseptal, and mid inferoseptal wall. And the findings here are a hypokinetic, non-dilated LV with extensive fibrosis in the spectrum of non-ischemic dilated cardiomyopathy. Findings are in keeping with Duchenne muscular dystrophy cardiomyopathy, and he has been referred for a follow-up cardiac MRI in 6 months' time. As we have seen, cardiac MRI is a valuable imaging technique in management of non-ischemic dilated cardiomyopathy. Tissue characterization is of paramount importance, and late gadolinium enhancement is not only important for diagnosis but for the prognosis of the disease. And I'd like to thank you very much for your attention.
Thank you very much. This was an important presentation for the use of CMR in the spectrum of dilated cardiomyopathy. Dr. Mitrousi, thank you very much for this important presentation. And you have delineated with your plethora of exams that have been done in specific settings, clinical settings and clinical examples, how valuable CMR has become in the setting of dilated cardiomyopathy. Thank you very much. I have no further question. Professor Adamopoulos, do you have a question?
Yeah. Can I? Thank you very much for another very informative talk, Dr. Mitrousi. In your first case with alcohol abuse, I would say, did you implant, in this case of dilated cardiomyopathy, did you implant an ICD and defibrillator? I'm saying so because some centers, even with low ejection fractions, of course, without laminopathy or without arrhythmogenic cardiomyopathy background, if there is no LGE, they're reluctant to implant defibrillators. Did you implant?
Well, actually, this patient went back to the national health system, and the feedback was that an ICD was implanted to him.
Right. Yes. We would do the same actually, but it's sometimes controversial after the Danish trial that even with low ejection fractions, if you do not have LGE, and of course there is no arrhythmogenic background, the defibrillator might not be that much useful prognostically. Anyway, in terms of prognosis as well, would you advocate, apart from the location and extent of LGE, myocardial deformation indices like GLS or LV torsion? They seem to offer additional prognostic information, isn't it?
I think you're a very important point here, Dr. Adamopoulos, and yes, it should be a part of our routine practice. We didn't used to have this because we didn't have the algorithm, but nowadays we're trying to get the algorithm where we have all the strain analysis and everything needed. So yes, we're going to have that as well in our reports. You're absolutely right.
Okay. Thank you very much.
Thank you.
Another comment from Sophia, from Michael. Shall we carry on, probably? Michael, you hear me? Sophia?
Yes, I want to comment something about regarding GLS.
Yes, absolutely. Would you like to take over, Stamatis?
Thank you.
I will actually for the next two. Yes.
Yeah, okay. I want to comment something regarding the use of GLS. There is only one study comparing evaluation of GLS in comparison with T1 mapping, and it was found that T1 mapping was earlier index of myocardial dysfunction compared to GLS, because in practice GLS represents systolic function. However, T1 mapping represents very early changes of the myocardium. So definitely we have to perform first of all T1 mapping, and irrespective of what we find using GLS, and GLS measured by magnet has a good correlation with GLS measured by echo. So irrespective of what we find on GLS, the most reliable index of very, very, very early myocardial involvement is native T1 mapping and DCB, of course.
Okay. Sophia, thank you very much for your comment. Always extremely useful, clinically meaningful. Thank you very much, Dr. Mitrousi. We will carry on with Dr.